Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for general and internal medicine. There are some changes you'll need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. So take a deep breath, relax, and let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, write acute on chronic congestive heart failure rather than congestive heart failure. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as acute systolic heart failure due to or secondary to hypertension. Think about the most current terminology to describe a condition or different aspects of the disease. For example, paroxysmal versus persistent atrial fibrillation, or typical or type 1 versus atypical or type 2 atrial flutter, or systolic versus diastolic heart failure, or both. Precisely designate anatomical site such as acute deep vein thrombosis of left tibial vein. Use exact dates when appropriate. For example, when a patient is admitted for acute myocardial infarction and the patient previously had a recent MI, document the exact date of the recent MI. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, inguinal hernias. ICD-9 has a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat, for example, pressure ulcer of the left ankle. So do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. As in ICD-9, ICD-10 continues to classify CAD by native coronary artery or bypass graft, and if the CAD is of a bypass graft, the type of graft. These should already be elements of your documentation. What's different in ICD-10? Combination codes are provided for CAD with and without angina. When your patient has CAD with angina, your documentation of angina should include the type, if other than angina pectoris, such as unstable angina or angina with documented spasm. For example, ICD-10 code I25.710 is reported when you document CAD of saphenous vein bypass graft in unstable angina pectoris. As physicians, we know what the clinical term acute coronary syndrome means, but in ICD-10, acute coronary syndrome is assigned to the non-specific diagnosis code of acute ischemic heart disease unspecified. If you can describe ACS more specifically as intermediate or insufficiency coronary syndrome, unstable angina, or coronary slow flow syndrome, these terms rather than ACS should be documented and will result in codes that give a more accurate picture of what you are treating. As in ICD-9, ICD-10 classifies myocardial infarction by type, STEMI versus non-STEMI. New in ICD-10 is the ability to report the site or location of a STEMI by coronary artery affected. If at the time of diagnosis you don't know the coronary artery, document as much as you do know, such as the wall of heart affected. Note that no additional documentation is needed for the location of non-STEMI. Here are some examples of ICD-10 codes for a STEMI. Note that the codes are first categorized by anterior or inferior wall, then additional specificity is provided for the coronary artery. Also note that certain terms crosswalk to certain codes. For example, a transmural myocardial infarction of the inferior wall is coded to other coronary artery. The key here is describing the MI as specifically as you can regarding the type and location in terms of the artery, wall, or other site affected. Unique ICD-10 codes are used to identify patients who present with an MI that is occurring within 4 weeks of a previous MI. When a patient is admitted with an MI and the patient has a history of a recent MI, document the date of the recent MI, the type as either STEMI or non-STEMI, and in the case of a STEMI, the wall of the heart that is affected. We see here in this example of medical record documentation that the patient presented with an acute STEMI of the LMCA, and the patient had a history of non-STEMI last month. Improved documentation for ICD-10 includes either the exact date of the previous non-STEMI or the number of weeks since it occurred. ICD-9 provided a single code for cardiac arrest. ICD-10 provides the ability to report the cause of the cardiac arrest when known or suspected as due to an underlying cardiac condition or other condition. Your documentation should indicate a cause and effect relationship by using words such as due to or secondary to. ICD-10 terminology describing congestive heart failure remains essentially unchanged from ICD-9. However, there is currently an opportunity for improvement in documenting this diagnosis. To provide an accurate picture of the patient's severity of illness and risk of mortality, you should specify whether the patient's congestive heart failure is acute, chronic, acute on chronic, and whether it is systolic, diastolic, or a combination of both. Additionally, you should document the cause or etiology of the congestive heart failure when known or suspected. An example of excellent documentation would be acute systolic heart failure due to possible or suspected alcoholic cardiomyopathy. New terminology in ICD-10 provides the ability to report the type of atrial fibrillation as paroxysmal, persistent, or chronic, and atrial flutter as typical or type 1, and atypical or type 2. When you can more precisely describe these conditions, these are the terms you should document in your notes rather than just atrial fib or atrial flutter. The only thing new here is that ICD-10 combines the anatomical site and the stage of the pressure ulcer into a single code. This required 2 codes in ICD-9. As you may be aware at this point, coders can use nursing or physical therapist documentation for the stage of the pressure ulcer, but you must document the diagnosis of pressure ulcer in your notes in order for it to be coded. It is also important to indicate if the pressure ulcer was present at the time of the patient's admission. Once again, there is not much new here. Like ICD-9, ICD-10 can classify gastroenteritis due to a variety of causes or organisms when documented. Specify the etiology and/or organism when known or suspected. Diagnoses such as gastroenteritis due to norovirus or suspect viral gastroenteritis convey more meaningful information than a diagnosis of gastroenteritis or a list of symptoms such as nausea, vomiting, and diarrhea. Document as much as you know or suspect about the gastroenteritis at the time of your evaluation or treatment. ICD-10 uses the term hepatic failure instead of hepatic encephalopathy. Additionally, ICD-10 provides for the ability to distinguish between acute or subacute and chronic hepatic failure, and with or without coma, which when documented will allow the reporting of how sick your patient is. Additionally, codes are provided for hepatic failure due to drugs, which you are encouraged to specify. It has been my experience that physicians often document the signs and symptoms of hepatic failure, for example, confusion, altered levels of consciousness, or coma, without actually documenting the underlying condition itself. So if your intended or suspected diagnosis is hepatic failure or hepatic encephalopathy, that is what you should document in your notes. But you also need to specify whether it is acute or chronic, with or without coma, and specify the etiology of hepatic failure, such as alcohol dependence. Obviously, it's appropriate to include the signs and symptoms in your notes, as long as you also include the diagnostic terms of hepatic failure or hepatic encephalopathy. ICD-10 provides several new codes for specific types of pancreatitis, such as idiopathic acute pancreatitis and alcohol-induced acute pancreatitis, while continuing to distinguish between acute and chronic, as was the case in ICD-9. However, there are continuing opportunities for improvement in the documentation of acute versus chronic pancreatitis and the specific etiology. Let's take a look at some actual medical record documentation on the next slide. We see here in this example of medical record documentation a final diagnosis of pancreatitis and alcohol abuse. There is no statement of acute versus chronic, and there is no linkage between the pancreatitis and alcohol abuse. The final diagnosis on the right tells a better story. It clearly states the pancreatitis is acute and shows cause and effect by stating due to alcohol dependence, which results in the reporting of alcohol-induced acute pancreatitis. The coder is not permitted to assume the alcohol caused the pancreatitis. Only you are able to document and use words such as caused by, due to, or secondary to. Additionally, consider the statement in the history, daily alcohol use. If your intended diagnosis is alcohol dependence, state dependence rather than abuse or use. Dependence and use or abuse are two different codes. What is new with urinary tract infections is that the diagnosis of urosepsis can no longer be coded in ICD-10. In ICD-9, a diagnosis of urosepsis defaulted to the code for an unspecified urinary tract infection. If you record a diagnosis of urosepsis in the ICD-10 environment, it will generate a query asking you for clarification. If by using the term urosepsis, you mean the patient has a UTI, then document UTI. If you mean the patient has septicemia from a urinary source, make sure to document this. For example, E. coli sepsis due to UTI. There's not a lot new with urinary tract infections in ICD-10. If you know the site of the infection, it's important to note it, such as cystitis, urethritis, or pyelonephritis, and if the condition is acute or chronic. If the infection is related to a device, you must document this relationship, such as UTI due to indwelling Foley catheter. Lastly, if you know the organism causing the infection, make sure to document the cause and effect relationship in your note, such as E. coli UTI. There is not a lot new with regard to the documentation of acute kidney failure in ICD-10. You must specify the etiology of the acute kidney failure, if known or suspected, and whether it is acute tubular necrosis, for example, or as a result of trauma or a procedure. You should avoid using the term acute renal insufficiency when you mean acute renal failure, as insufficiency is assigned to a generic or non-specific code in ICD-10, which will not do justice in explaining your patient's severity of illness and risk of mortality. Not much has changed in ICD-10 with regard to the documentation of chronic kidney disease either. You must specify the stage of CKD, stages 1 through 5, or end-stage renal disease. Additionally, you must also indicate the etiology, such as diabetic CKD or hypertensive CKD. Try to avoid using terms such as chronic renal insufficiency and chronic renal failure interchangeably, as they are coded differently and will result in inaccurate classification of your patient's severity of illness and risk of mortality. Classification of asthma is an example of the use of updated terminology in ICD-10. Asthma is now classified as mild intermittent or mild, moderate, or severe persistent. Documentation of acuity remains unchanged from ICD-9. You should continue to document the presence of an acute exacerbation or status asthmaticus. For example, a diagnosis of severe persistent asthma with acute exacerbation is classified to J45.51. Classification of pneumonia and pneumonitis is very similar to ICD-9. It continues to be important for you to document the type of pneumonia, for example, aspiration pneumonia, and the organism, such as Klebsiella, when known or suspected. Remember, a coder cannot base code assignment on a sputum culture or cytology report. You must document the organism in your note, indicating a cause and effect relationship, such as Klebsiella pneumonia or pneumonia secondary to or due to Klebsiella. ICD-10 provides combination codes to capture acute bronchitis, due to 8 different organisms. Document the specific organism causing the acute bronchitis when known or suspected by using due to or secondary to indicate cause and effect. Note that you must document the word acute when your intended diagnosis is in fact acute bronchitis. Otherwise, a diagnosis of bronchitis is assigned to a code describing bronchitis not specified as acute or chronic. Chronic bronchitis has its own classification. If you can further specify the type of chronic bronchitis, such as simple, mucopurulent, or both, a unique code describing the specific type will be reported. ICD-10 differentiates COPD with acute lower respiratory tract infection from acute exacerbation of COPD without infection. When an infection is present, document the specific infection and organism when known or suspected. When respiratory failure is present, it should be specified as acute, acute on chronic, or chronic. Dependence on supplemental oxygen should also be indicated when applicable. Most types of emphysema were grouped into a single ICD-9 code. What's new in ICD-10? Separate codes are provided for specific types of emphysema. When you document the specific type of emphysema, such as unilateral, panlobular, or centrilobular, a unique ICD-10 code for that condition can be reported. What's new here? ICD-10 has a new combination code to capture the patient who has a pulmonary embolism with acute cor pulmonale. The takeaway here is the documentation of cor pulmonale and whether it is acute or chronic. What stays the same is that you still need to document the type of pulmonary embolism, such as septic or saddle, and whether the pulmonary embolism is acute, chronic, or healed or old. History of PE can be interpreted to mean the patient has had the condition for a while, such as in history of hypertension, or interpreted to mean the patient no longer has the condition. Documentation of chronic pulmonary embolism versus healed or old PE makes a clear distinction and assures that the severity of illness of your patient is reported accurately. Severity of illness is increased when a patient has a chronic pulmonary embolism, but there is no impact on the severity of illness when the patient has a personal history of pulmonary embolism. Note that documentation of healed or old PE results in the reporting of a code for personal history of pulmonary embolism. ICD-9 did not differentiate between a diagnosis of respiratory failure and acute respiratory failure. The good news is that ICD-10 does. When appropriate, you should document respiratory failure as acute, chronic, or acute on chronic. Additionally, also specify if hypoxia or hypercapnia or both is associated with the respiratory failure. Remember, coders cannot interpret the results of tests such as arterial blood gases. They must rely on your documentation. At times, we see respiratory insufficiency and respiratory distress used interchangeably with respiratory failure. Respiratory insufficiency and distress are signs and symptoms of an underlying condition and are coded differently from respiratory failure in ICD-10. Be clear on your intended diagnosis. Severity of illness will not be reported accurately if you use one term when you mean another. Additionally, document the cause or etiology of respiratory failure, such as due to COPD, surgery, or trauma. When pulmonary insufficiency is due to surgery, documentation should describe a cause and effect relationship and it should be further described as acute or chronic. For example, acute pulmonary insufficiency due to surgery 2 days ago. FYI, one of the differences in ICD-10 is that pulmonary insufficiency due to surgery will be classified as either due to thoracic or non-thoracic surgery. Other causes of pulmonary insufficiency, such as chest trauma or hemorrhagic shock, when known or suspected, should also be documented in terms of cause and effect. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for major depressive disorder, single episode, unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply said depression. If major depression is not your intended diagnosis, consider adding additional details to your documentation when known. It will change the code and better describe what you are treating. For example, major depression could be further specified as single episode or recurrent. In either case, is it mild, moderate, or severe? If severe, it is with or without psychotic features. Is your intended diagnosis something else other than major depression, such as adjustment disorder, for example, grief reaction, with depression and or anxiety depression, or depressive neuroses? According to published Medicare inpatient hospital data, the code for unspecified depression appears on 1/5 of hospital records covered by Medicare. We can do a better job identifying patients with major depressive disorders as compared to those with other forms of depression that are less severe and require less resources. Given the health risks of obesity and the number of obese people, it is important for us to be able to continue to track the prevalence and cause of obesity among U.S. adults and children. Since overeating is the #1 cause of obesity, it should come as no surprise that ICD-10 has a new code for nutritional obesity or obesity due to excess calories. So consider incorporating nutritional obesity into your vocabulary when applicable. It's a few less words than obesity due to excess calories. If your patient has morbid obesity, also document if alveolar hypoventilation is present. ICD-10 has a single combination code for it. As in ICD-9, ICD-10 continues to classify obesity due to other causes, such as due to drugs or endocrine disorders. The look and feel for codes describing diabetes have changed, but the level of detail describing the disease remains mostly the same. Therefore, your documentation doesn't need to change as long as you are currently documenting the type of diabetes as type 1 or type 2 and any associated complications. For example, diabetic peripheral angiopathy, diabetic autonomic neuropathy, or diabetic foot ulcer. The good news is that ICD-10 uses single combination codes to describe the disease. ICD-9 usually required multiple codes. Take, for example, the diagnosis of type 2 diabetes with diabetic peripheral angiopathy with gangrene. This diagnosis required 3 codes in ICD-9, but in ICD-10, 1 code reports everything. An additional code is assigned when you describe the patient's diabetes as poorly controlled or out of control. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. ICD-10 has greater specificity for anatomical site and usually requires documentation of laterality for paired organs. Be sure your documentation is as specific as possible when identifying anatomic site. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be metastatic cancer to right lower lobe of lung from breast. Patient had left mastectomy 1 year ago. This documentation clearly identifies the primary and secondary sites and states the primary site is no longer present, all of which are factors considered in code assignment. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient was admitted due to acute exacerbation of systolic heart failure. Patient has age-related dementia and forgot to take her digoxin as prescribed. Or, patient cut her dose in half this month because of financial issues. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.